Oh, that's worked. Charlie, does that seem to have worked? Yes. Okay, great. And yes, I think that's everything. So without further ado, I'll pass over to Nikki and Trevor.
Yes, good afternoon and thank you. Just to give you some background before I pass on to Bridgitte, SportsMed Products has been working with a Finnish company called Her, who are well known for producing strength training equipment, particularly aimed at the active aging market. And we already supply a large number of care homes in the UK with gyms to enable movement and strength. Her stands for Helsinki University Research, and so we're very keen on backing up everything we do with good clinical research. So we've been working with the University of Stirling to sort of research the products that and how they increase strength and how they help the aging community. Bridgitte has been a leading part of this with her PhD, and I'm sure you'll find what Bridgitte has to say very interesting. So without further ado, I'll hand you over to Bridgitte. Bridgitte, it's all yours.
Oh, goodness, what an introduction. Thank you so much. Thank you, Ewan and Charlie, for setting all this up, and thank you to Trevor and Nikki for their support, ongoing support and support here today. So good afternoon, everybody, and hello. My name is Bridgitte Swales, and as Ewan said, I'm a strength and conditioning coach, and I'm a researcher at the University of Stirling, which is where I'm completing my PhD. And my research focuses on the impact of resistance training on multidimensional health and successful aging. So today I'd like to talk to you about this relationship between healthy aging and strength, and specifically in relation to frail and pre-frail older adults in residential care. So spoiler alert, here are my key messages up front. Stronger is better, strength matters, and strength changes lives. And you've jumped ahead there, Shy, but you know, I'm happy for that. I'm still on the first slide, but that's okay. She's keen. So what you can see on this first slide are some of the participants who were actually involved in the research studies that form part of my PhD. So these trials were actually based in a residential care home in Birmingham, in England, and with the strength equipment, as you can see here, actually installed in the communal lounge area. And these wonderful people that I got to work with, they taught me a lot about living a long, happy life and the challenges and rewards of improving strength and quality of life from a baseline of frailty, weakness, and limited mobility. They had no experience previously of working with resistance training, and despite a lifetime of coaching strength, I had no previous experience of working with frail older adults. So as you can imagine, it was quite a learning process for us all, and I'll be sharing some of the stories and my research findings throughout this webinar. Next slide, please. I've been excited to do that, Charlie, and steal my moment. Thank you. So today we're going to look at four key areas. So I've got these flagged up on here for you. We're going to look at defining and explaining some key terms relating first to healthy aging, including ones that I've mentioned already, like multidimensional health and successful aging. And then we're going to take a broader look at a consideration of physical activity, including being clear on what it is, what the current recommendations are for older adults, and then into the specifics of resistance training. So what is resistance training? What are the risks and the benefits? Why we should all be doing it, and why this becomes even more important as we age. So I'll then go on to discuss the details of my research with frail and pre-frail older adults in residential care, and how that supports and expands on current evidence, and in some parts actually challenges some of the current evidence that's out there. And then we'll go on to look at that and some other findings and consider the practical application of this, and that kind of to suggest like where that leaves us now, what steps we really need to take, how can we change perceptions of older adults in residential care in relation to strength, and most importantly, what actions we can take. Because what needs to happen next is based on the fact that we know building and maintaining our strength with regular resistance training exercise is one of the best long-term investments we can make, whatever age and whatever stage of life. Next slide, please, Charlie. So what is healthy aging, and why does any of this matter? Well, healthy aging, according to the World Health Organization, is a process of development and maintenance of the functional ability that enables well-being in older age. So this means that healthy aging, it's about improving and maintaining functional ability. And that means to be able to perform activities of daily living and the ability to learn, contribute, build and maintain relationships. It's about living well and it's about growing older better and supporting older adults to live life with health, with meaning, purpose and dignity. And this term healthy aging, it's being increasingly used both informally and in research situations. And it starts to recognise that the impact of the individual's intrinsic capacity, and by that I mean their full physical and mental ability, includes ability for physical movement, their vitality, their energy, their sensory, cognitive and psychological wellness. And this is what I mean by multidimensional health. It's a big picture. And what we see is that positive change in any or all of these is strongly associated with increased levels of independence and increased quality of life. So again, I'll ask the question, why does this matter? Well, it matters because we're living longer. So increased population age is recognised as a defining global trend. So there's an urgent need for us to really understand all these different factors that influence healthy ageing and well-being. For instance, the UK population we know has been gradually getting older, and this trend is expected to continue. So at the moment, there's over 11 million people aged 65 and over, so that's about 19% of the total population. But in 10 years' time, this will increase to about 13 million. So then that starts to be 22% of the population. So even with a recent deceleration in this increase in lifespan, so that's total years lived, the lifespan changes over the past 50 years. They're not being matched by additional years lived in good health, and that's health span. So it's this trade between lifespan, full life lived, and then the healthy years of that. And the extra years that we're getting often don't seem to be actually lived in good health. So addressing this health span is a real challenging problem for governments, for health organisations, for individuals and for broader society, and particularly when we think about the economic cost of ill health in older age. So what can we do to help us age well? Next slide, please, Charlie. So being physically active, this is the real crux of the matter. And if physical activity were a drug, we would refer to it as a miracle cure due to the great many illnesses it can prevent and it can help treat. And they're not my words. I wish they were. They're rather marvellous, aren't they? But I stole them from the UK Chief Medical Officer's report in their most recent physical activity guidelines. As you can see on the slide, there's an infographic there, and that's a summary of the current guidelines and the potential benefits. And they go on to say that the evidence in favour of exercise is compelling and the message is clear. And that evidence and that messaging is what we're really going to consider today. So I genuinely doubt there's any lifestyle habit that any of you could adopt that's as effective as exercise, and that's going to reduce your risk of several chronic diseases, including type 2 diabetes, dementia, cardiovascular disease, and mobility problems. So by being physically active, people can age well, they can preserve the mobility and the strength to remain independent for longer, and they can contribute to their work, to their communities, and stay connected to others. You can see on the infographic in front of you that it draws attention to being active for at least 150 minutes a week at moderate intensity, or at least 75 minutes a week at vigorous intensity. It talks about minimizing inactivity and sitting time and building strength on at least 2 days of the week. Now, the report also talks about 3 different groups within older adults, because we know that there's quite a lot of somebody being labelled as an older adult. It can be very different. And this report talks specifically about more nuanced advice. So they talk about like active older adults. They talk about those in transition whose function might be slightly compromised. And that's probably like our pre-frail older adults, and then right the way to frail older adults. But interestingly, this real push for more strength and more balance work is consistent across any of those groups. However, there's a real challenge to get this message heard, particularly by older adults, and specifically in relation to building strength. And so you can see again on the infographic, the Chief Medical Officer's report really attempted to bring strength training right to the front and centre. And you can see that message clearly there, because we know that the loss of muscle strength is a primary factor in the loss of independence. So it needs to be front and centre. Next slide, please, Charlie. So on this next slide, we can see strength and balance ability across the life course and potential ages or events that might change it. So ability, that's on the vertical axis. You've got strength and balance there. And then life course is along the horizontal one across the bottom. And you can see also that disability threshold there in the center. So on the figure there, the green line, that's the top line, that's successful aging. So that's with good health and regular strength and balance activity all through the life course. So you can see they pretty much stay above that disability threshold even into older life. Whereas the blue line, that's when you're getting declines in strength and balance if it's not included as part of your activity throughout your lifespan. And you can see there in older life, that blue line drops relatively sharply into that disability threshold. So generally, muscle strength and bone strength and balance ability, it increases in childhood, you can see it there, and then it peaks in early adulthood, and then it followed by a decline, and even more of a decline in older life. We know that's going to happen. There are physiological changes, but we try to offset it as much as we can by being physically active. So this rate of decline, it's mostly affected by what we call modifiable lifestyle factors. So that's things like exercise, nutrition, whether people are smoking, consuming alcohol, and their diet. But there are like other single events such as accidents, as you can see on here, prolonged immobility, falls and illness that might have a distinct impact on that pathway as well. So specifically with our older adults and those identified as frail, falls are a major concern, and particularly if this then means that after that somebody's immobile for a long period of time or they have a stay in hospital, because any inactivity means a loss of muscle strength and muscle mass, whatever age we are. But for those who have already got low strength levels and frailty, this can be really significant. There's no buffer there, is there? And to give you some indication of that, strength can decrease by as much as 3 to 4% per day during the first week of immobilization after a fall if somebody's in hospital. And more than 50% of older adults will experience functional decline after they've been in hospital. And this then aligns with loss of quality of life and independence. And this decrease in muscle strength, it can negatively affect muscle function. And by that, I'm talking about things like the ability to get out of a chair, walking speed, climbing stairs, and the capacity to kind of rebalance ourselves if we trip. And to really give you some idea of what it means in real life, everybody needs lower body strength to be able to stand up out of a chair. And that's about 35% of your body weight to be confident that you could get up without actually having to use your arms. So typically, when we look at some strength tests that have been done just on the strength of the lower legs on people aged 50 to 70, only 2% of men and 14% of women would have trouble getting up out of a chair. But once somebody gets over 70, more than 25% of people would not be able to get up out of a chair. And if you go now to the over 75, so we're up another age group, and you think about this, you're sitting and you're standing, sit to stand test, men tend to do better, and most would have not too much difficulty getting up out of a chair. But for women, it's a very different story. And nearly 10% of women aged 75 to 79, and then over 40% of over 85s would find it a real struggle to get up, and this is directly related to levels of strength. So if we go back again, let's focus in on the slide here. We can see this age-associated loss of strength. It accelerates as we age, and we know that this has strong implications for independence and levels of independence right across the adult lifespan. So we lose about 50%. I'm just giving you all the good news in one go, aren't I? We lose about 50% of strength between the ages of 25 and 85 if we don't do anything about it. But it really it accelerates after the age of 50, and then you're looking at about 15% loss per decade. And in older adults over the age of 75, they can be losing muscle mass, which is probably what we see as a change in body shape and body composition between 2 and 4% per year. But actually you lose strength faster than you lose muscle tissue mass, and losing strength can be 2 to 5 times faster than that, and that's because of other aging issues connected to like changes in the neurological and the neural system. But remember, lower physical capability, and that's strength, balance and walking, it's consistently associated with higher mortality. And that means that strength training and balance activities are super important for all of us right across the whole life course, but even more important as we move into those older life stages. Next slide, please. Thank you. And I'll talk you through this slide. So aging is associated with this concept of sarcopenia, and sarcopenia is a word that you might have heard. It means an age-related loss in muscle mass, in strength and function, and it's inversely related again to morbidity and mortality. So on the previous slide, we talked a lot about muscle and bone strength, And on this one, we're going to really focus in on changes to muscle mass and muscle tissue. So if you see here on the slide, the study that they did, they wanted to find out if high levels of exercise prevents this loss of lean muscle mass and strength that we see in sedentary older adults. So for this particular study, they examined a cross-section of 40 high-level or masters athletes who were aged between 40 and 81 years old and trained 4 to 5 times a week. And they looked at all tests of health and activity. They looked at muscle strength. They did MRIs of thigh muscle, which is what we can see here on the slide. So the images I want you to have a look at here, as you can see at the top, that's a 40-year-old triathlete, so very active. In the middle is an inactive, so very sedentary older individual, older man, and then at the bottom, a very active 70-year-old. Now, even if you just looked at these and just take a look at the visual there, there's not a lot of difference between that top one and the bottom one. And it's exactly what they found in the study. They found that there was virtually no difference in muscle area or lean mass. It didn't decrease with age, and there was no significant change in strength. But if you then look at the one in the middle of the 74-year-old, you can see significant increases in, they've got it labeled there, adipose tissue, that just means fat, and then a loss of muscle tissue. So the kind of darker area, which is the muscle tissue, has really shrunken, but the fat area is much, much bigger. So what does this tell us? Well, this study totally contradicts what we would like the common observation that you're going to lose muscle mass and strength, and that just happens because you're getting older. So what they did with this study, well, they were really suggesting that it's about chronic disuse rather than just muscle aging. So when we study older people who continue to train at high levels, we take that disuse out of the picture. And if they were still continuing to exercise at high levels, there was no decline in strength and in mass of the muscle tissue. Now, I'm not suggesting that all our older adults now need to go out and train at a high level 5 days a week, but it does show us that muscle mass due to disuse is preventable. And if we can prevent or reduce strength loss and effectively maintain muscle mass and strength together, we can decrease or eliminate falls, functional decline, and the loss of independence that we commonly see in frail older adults. So our take home on this is that muscle disuse is preventable and reversible. Muscle use, as in exercising all the time, in the form of resistance training, is a really effective way to counteract this. Next slide, please, Charlie. So now we'll move on and actually look at resistance training. So what is resistance training? So resistance training is a specialized method of physical conditioning, and that means that you'd be working against some kind of resistance load, and that might be body weight, it might be free weights, it might be machines, and we do that to try and improve health, fitness, and athletes might use it to improve performance. And what we're learning more and more is that the health effects of resistance training extend far beyond just increasing muscle mass and strength. So a recent systematic review, and a systematic review is when a researcher pulls together all the evidence and all the review papers and puts it all together to get a total overview. They found that participation in any strength promoting exercise was associated with a 23% reduction in all-cause mortality and a 31% reduction in cancer mortality. They found that resistance training can help with the management and treatment of many common health conditions. So that would include things like depression, anxiety, cardiovascular disease, chronic lower back pain, osteoarthritis, and hypertension. Regular resistance training is associated with positive changes in multiple health-related biomarkers. So that would be things like insulin sensitivity, body composition, blood pressure. It's now been recommended for the prevention and management of type 2 diabetes and other metabolic disorders. It's a safe and effective way to improve physical function, muscle mass and strength, and quality of life in cardiac rehab and cancer patients as well. So it really stands out that it's our primary countermeasure to age-related chronic disease. Next slide, please. Thank you, Charlie. And it also positively impacts not only on muscle mass and strength, but it positively impacts on other tissue. So that would be cartilage, ligament, and bone. So it's one of our first line defenses for our older people that may be at risk of osteoporosis or losing bone mass and bone density. The position statement that you can see there on the slide and then the associated infographic, this is from the United States National Strength and Conditioning Association, and this is one of the largest organizations dedicated to coaches, researchers, and scientists. And this document provides an overview of all the current research and evidence-based recommendations for resistance training for older adults. And I checked this morning, it's about 53 pages long. So again, a little bit of light reading for you, but the summary is there for us all to see. These are the key messages here. And it talks all the way through about resistance training for older adults, including frail older adults. It supports resistance training as a powerful intervention. It talks about how it can offset physical vulnerability and frailty. It supports chronic disease management, psychological well-being, quality of life, and healthy life expectancy. Now, a part of it that is of particular interest to me for my research is around older adults in residential care. And I quote, they say that resistance training interventions have demonstrated that strength and functional capacity of older adults can be significantly improved even in residential care settings. They know that there are clear benefits for it, and this should really actively encourage people working in those environments to seriously consider getting proper training equipment into their facilities. They also go on to say that there is no evidence of any adverse events or serious injuries, and from their perspective they would say that resistance training is safe even for frail, functionally impaired and very elderly nursing home populations. Next slide, please. Now, critically, we're not getting a lot of uptake for people getting involved in resistance training. So despite all the great things that I've told you about, the unique physical and mental health benefits of engaging in regular resistance training and a growing consensus of how important it is to reduce chronic disease risks, we still talk about these as resistance training being the forgotten element. And this is a fabulous paper by Strain that was published in 2016, and it was basically called the forgotten guidelines in and around resistance training. So it tends to be the part that's less well known and less often achieved by people. So even when people are saying they're physically active, they tend not to be focusing on resistance training, or they're not sure what it is or how to implement it. And this is especially true of older adults. So in the 2021 Health Survey for England, they reported that only 17% of those aged over 65 met the muscle strengthening guidelines. And another study that I was involved in recently, we found that only 12% of Scottish older adults met the guidelines of strength training. And you can see similar presented here on the slide. So although there's mounting evidence to say that it's super effective, older adults, particularly those in residential care, are often really overlooked. And a recent survey looking at exercise programs that were offered to older adults who had sarcopenia or frailty, which is probably a lot of our population in residential care, that only 9% of them actually had any resistance training of any relevance that was included in those programs. And likely another one of our big challenges is in this environment is cited in the paper. They go on to say that we know resistance training, it takes time and it takes resources for exercise professionals to deliver, and it takes a significant commitment from our older participants to be involved in it as well. So it's really important that these programs are conducted in a way that deliver the best possible outcomes. If they're going to get somebody strong, they need to be proper resistance training to achieve that. We're looking at how we can make these programs optimal. And their findings linked with my research findings as well, that really we need longer programs. So it's about lifelong strength with higher intensity and really focused on resistance exercise. And with data suggesting that there's over 17,000 care homes in the UK, and that would be an estimated figure of more than 400,000 older adults in residential care, we've got quite a big job on our hands to make those changes. Next slide, please, Charlie. Thank you. So at some point, critical activities of daily living are going to depend on how strong you are. And that's my message to everybody listening today, including myself. Plan now to invest in strength to buffer yourself against the effects of aging. And that's whenever now is. And that might be wonderful, friends. That might be Iris there on the left. She's investing in strength training because Iris was one of my participants in the study, and she was using a walker and was being actively encouraged to use a wheelchair, and she didn't want to be in a wheelchair. So that was her why did she want to do strength training? And then Sheena, fabulous, she was kind of our role model for one of our studies. She wanted to be able to carry cups of tea to her friends at the church meeting, and she felt like she didn't have enough balance or stability to be able to do that, and that was one of our big wins. She was thrilled when she was able to do that. And then Norman, Norman is there with me on the right hand side, not only trying to teach me how to play blues harmonica, but really he wanted to be strong so that he could look after his wife, who was in the same residential care home but had dementia, and he wanted to be strong to be able to work with her. So it's finding that why. It really can transform people's lives, whatever it is that they're looking for out of that strength work. Next slide, please, Charlie. Thank you. So I've mentioned frailty quite a few times, and it's a key part of the inclusion criteria for my study. So I'm just going to explore this a little bit and explain what I mean by frailty. So it's an age-associated multidimensional clinical syndrome. That's its posh explanation there. And we see it as weakness, it's reduced physical resilience, decreased energy and well-being, and often associated with adverse outcomes, so disability, falls, hospitalisation. And NHS data, for example, suggests that people living with severe frailty have over a 4 times greater risk for any of these negative outcomes. And there's no standardized way, as I found when I was doing my research, to define or assess frailty. So the criteria that I used is the Fried frailty criteria, and that was devised by a professor, as she is now, Professor Linda Fried, and she used that so that we could categorize and classify where somebody was on that frailty continuum. And there's 5 key components there. So muscle weakness, so you would assess that using grip strength. Unintentional weight loss, did they lose more than 10 pounds in weight over the last year without meaning to? Did they report that they were exhausted and tired? Did they have slow walking speed and low levels of physical activity? So if somebody is ticking 3 or more of those boxes, that would mean that they were being classified as being frail. 1 to 2 is pre-frail. So that's we would see that that's a stage before somebody going into frailty, and 0 would be robust. So we've got this whole framework to try and figure out where people sit on that. And as I'll explain, people can move up and down that scale, and there's a lot that we can actually do to offset, to slow, to reverse, and reduce the risks of developing frailty. Next slide, please. Thank you. So this is when we get into my research here. So the CARE there is an acronym for Keeping Active in Residential Elderly, and it was some feasibility trials to actually look at resistance training interventions in a care home with frail and pre-frail older adults. And what I wanted to do was to assess the feasibility of doing a larger future trial and to see what the impact was on multidimensional health, on functional capacity and wellness of frail older adults in residential care. So we ran these studies, as you saw on some of the other pictures, in a residential care home in Birmingham. The management there were just fantastic. They were super supportive. They had a dedicated wellbeing team there. They had a really strong sense of community, and they were really open to working with research communities to try and improve the wellbeing of their individuals in their home. And I initially recruited with the help of the wellbeing and the care staff, and then gave an introductory talk about the trial. Residents were free to volunteer to see if they wanted to be involved in it, and they were also free to leave the study at any time without having to give a reason as to why they might do that. And the criteria for being involved in the study was based around that Fried frailty criteria that we just looked at. So all participants needed to be over 65 with pre-existing frailty, and I ran 2 studies, and the first one was with frail older adults, so they needed to be scoring 3 or more, and then the pre-frail one was at scoring 1 or 2. And each trial ran for 20 weeks in total, and that included recruiting, eligibility screening, pre and post tests, follow-up interviews, focus groups, and then, most important, of course, their strength training intervention, which was a 6-week training intervention. And we had 11 older adults participated in each of those studies. And all exercise sessions took place in the lounge of the residential care home. It was a group-based activity because we also wanted to see if there'd be changes in kind of socializing and people working together. And I was there to support and encourage every session. Next slide, please, Charlie. Thank you. So resistance training, as I've said, it can involve body weight, free weights, resistance bands or machines. But in this instance, I was incredibly lucky that her and SportsMed agreed to loan me equipment for my studies. So these machines that you can see here, they're pneumatic. They operate with web-based software. So people would just log in with like a smart card, and it would remember and say their name and what exercises they were doing. And they're specially designed machines, so you could have an initial load of 0 and you could make very, very small adjustments, as small as 100 grams on those. We could limit the range of movement. We could change where the roller sat. So for example, one of the residents had some really painful varicose veins, so we could move the roller so it was in a different place so that it didn't bother those. And these are specifically designed for rehab, for inclusive wellness and for active aging programs. Next slide please, Charlie. So the exercise prescription that I used, this was based on the current guidelines that are out there. But the reality is we don't actually know the most effective prescription for frail older adults or those in residential care. But we know that from a practical perspective, the most effective prescription is the one that somebody enjoys and the one that they do with regularity. So that fit principle there, you can see we needed to know what was the frequency, how many times a week were they training, what intensity were they doing the resistance training at, about how long did the session take them, and what type of training it was. So as you can see there, it's progressive resistance training. So that meant that we could program into the machine so that every time they were able to complete a series of exercises, next time it would automatically increase the load a little bit so they'd get progressively stronger. And like I said, that was one of the beauty of me being spoiled with those fantastic bits of equipment that we used. Next slide, please. And as part of my study, I come back to this term multidimensional health. So I was interested in a whole range of different things. So the people, there's Iris there in the centre, giving us a big smile. That are my participants. We looked at functional ability, so things like sit to stand, that's things like walking speed. But we also took blood tests, look at inflammation, stress markers. They did a whole range of psychological and emotional measures, cognitive scores, and measures of social support. And you can see John there filling out some of those many questionnaires that they very patiently did for me. And we also collected qualitative feedback from interviews and discussion groups. And to monitor strength levels, we used grip strength, and we also used some isometric strength testing on the equipment. And that was to look at the reliability and validity of the equipment. And I just published another paper on that as well, which you don't know about, Nikki. That's more good news. Next slide, please. So what did we find? Well, I think the interviews were the bit where we really found out what people thought of the studies. And there's a couple of quotes for you to read. And another couple of quotes that didn't quite make the cut was one of my favourite ones. Again from one of the participants, and he said, I think everybody has really enjoyed it here. It's a tremendous thing for a home like this, especially, he said, for the older people who are not so strong so they can get better as well. Now, to give you some idea, this participant himself was in his 80s, but he was very keen to make sure that the older people could get strong as well. And one of the staff members explained, they said, it's an investment. It's got to be here. I'm afraid it's got to be here. It's the way forward. I think it's the best thing that we can do, and put the equipment into a care home. Participants, they just spoke about they really enjoyed their exercise sessions. They built confidence. They got new skills with technology, because they had to learn how to log in with a smart card. They had to use how to learn the technology. And it was something that we were a little bit concerned about. Would they be able to do that? But actually, they absolutely loved it. And even the staff and the care team, they were really surprised that high levels of adherence is the posh way. They were really surprised people kept turning up and actually got involved in it and did their resistance exercise, and they were really enthusiastic about it. Next slide, please. And what we did see, you can see here on this image, on this figure that I've put in there, is we actually saw, which was quite incredible and we never expected it, was that the participants at the beginning, they were scoring an average of 3 on their total score. So as a group, they were frail. And then by the end of their strength training, which continued through their follow-up, they'd actually changed status from being frail to being pre-frail. So it actually moved them like a whole into a whole new bracket. And that was literally in the 6 weeks there. So we genuinely weren't expecting that, but it goes to in support of other research is coming out now to say that frailty, can be reversed, can be offset. We can limit the progression of frailty. And like I say, multiple other studies are coming out to support that as well. Next slide, please. And what else did we see? Well, we saw that people talked about being more confident with their movements. We saw that they had improved in their walking speed, that in all the tests that we did, that they said they felt better, they felt happier, they had greater well-being. And wonderful Rex and Barbara there on the far left-hand side, on that particular piece of equipment, people had to like walk into it. So then when they were getting off it, they had to step back off it. And that was really challenging for a lot of people when we started. They weren't sure about it. They didn't have the confidence to do it. And by the end, everybody was like, oh, it's fine. I just pull my leg over and step backwards out of it. So it was really great to kind of see people just really changing their perception of their ability and their confidence. Next slide, please. Now, the feasibility studies, they were small groups of people, so they did have some limitations. And those key limitations were, it was quite a short time. We ran them over. It was a relatively small group that we worked with. And the equipment. Now, the equipment just comes up as a limitation because not everybody may have access to the fabulous equipment that I had access to. But the reality is when you start to look more at the current research into the use of technology with older adults, the research suggests that the full potential of technology isn't really being used to enhance the quality of residence and in care homes, and it can play a really important role. And we thought that it would be a barrier, but actually the opposite was true in this instance. So you don't need it. You can do strength training, like I say, using body weight, using other equipment, but in this instance it was a way that we could also expose older populations to new technology and help them understand and keep up to speed with what was going on with that. Next slide, please. And another thing which is super important, not something that I zoned in on my research, but it is a factor, and it would be a factor if I was going on to do a further study. You need to be able to look at the kind of costings in and around this to see if it's viable in a care home. So more again, this is from the UK Chief Medical Officer's report. They say that regular physical activity can deliver cost savings for the health and care system, as well as wider social benefits. And here on the slide, you can see there's some current research out there. So there was a paper published in 2021 when these particular researchers attempted to quantify the economic cost of muscle weakness in the UK. And they did that by trying to calculate the excess economic burden caused by people having high levels of muscle weakness. And they used a large sample of UK-based men and women who were born in the 1930s and still living in the early 2000s. And what they did was they defined muscle weakness by low grip strength, which is what we used before, and then they used standardized unit costs for each element of additional care that might be needed. And among the participants, they looked at excess economic burden with muscle weakness based on about £3,000 per person per year, and then multiplied that by the percentage of UK population that would fall into that age bracket. And they assumed then that the prevalence of muscle weakness would be the same, and that's how they get to this 2.5 billion cost per year. And yes, there are clearly limitations with that particular study, but it's a really good paper, and it shows credible estimates of the cost of muscle weakness. And as another example, the treatment cost associated with sarcopenia, that's a term I mentioned earlier, around muscle weakness and strength in the US health system, they're estimated to be in the region of about $19 billion per year. Remember, severe falls reduce the quality of life. These can exacerbate cognitive function decline, and then that all reduces independence and increases care costs. So this is becoming an area of increased interest for people researching in this area. Next slide, please, Charlie. Thank you. But how do we actually increase participation, and why are we not getting people involved in resistance training, particularly older adults? Is it our messaging? Is it how we're trying to work with older adults with resistance training? Well, maybe. A lot of the current research suggests now that maybe we put too much emphasis on the medical or the longer term benefits, rather than thinking about what really matters to older adults. And the research tells us what really matters to older adults is community, fun, social interaction, improvements in mood that they might see within 1 or 2 sessions, being independent, improving their independence, having the strength and the ability to play with their grandkids, and improving their movement confidence. So these are things that can change quite quickly, and these are the things perhaps that we need to be focusing on. And again, if we look at what's going on often in care homes, the research suggests that often care home residents spend as much as 80% of their day sitting and sedentary. And again, this low levels of activity, that again can link to increased fall risk. It contributes to deconditioning and functional loss. So perhaps we're sending some of the wrong messages about movement, and really, rather than people worrying about falls, we should be thinking about how we can get people stronger and improve the quality of their movement. So is strength training the answer for all care home residents? Well, yes and no. It's like that. We always joke in strength and conditioning and say the answer to everything in strength and conditioning is it depends. So yes, it is the answer if we can get an effective dose and duration. So thinking about it being a long-term investment for people doing resistance training. And then the no is it. Some people just might not want to do it. They might not be interested in it, or care homes may not have the staff or the expertise to be able to invest in it. But exercise is medicine. Yes, it is. And as it's medicine, it needs to be personalised, it needs to be individualised, which is what we were able to do with our resistance training intervention. And we need to start with an effective dose. But we really need to focus on the barriers and the motivators to resistance training for older people. And they are very different to what we see with different age groups. And having a strong awareness of that is something which is going to encourage older people to get involved and hopefully get them to get the benefits of resistance training. Next slide, please. Thank you. So building and maintaining strength with resistance exercise, we know it is a primary countermeasure. It's got the ability to improve strength, quality of life, reduce frailty in older adults, and especially those in nursing and residential care facilities. So my take-home messages, which I'll say again, stronger is better, but we need to make sure that we get progression within that and we get an effective dose. And maintaining physical function and strength can be the difference between independence and dependence. Thank you so much for your attention.
Thank you, Bridgitte. That
Thank
was
you.
a fascinating presentation. Thank you. Yeah, no, really, really great. And just some immediate thoughts from me on that. Hearing about the prevention agenda, that's obviously something that we hear so much about in the policy world. So to see a really practical solution for how care providers can help bring that into their service. And also falls, that's a huge area of work that we're focused on. We know about the cost of that to both the NHS and also to individuals themselves. And just something that really stuck with me was you mentioned about some of the goals of the individuals in that study. It was things like seeing their grandkids, maintaining that bit of independence. It's not about becoming a triathlete, as you said, but it's about meeting the goals that individual wants to, which I think is really what social care is all about. So I think that was a really excellent point. Does anybody have any questions for Bridgitte, for Nikki, for Trevor? If not, I've got one that we can kick us off with. We've got Lauren just saying in the chat there, thank you, Bridgitte. As newly qualified PT myself, this was fascinating. That's great to hear. Thank you, Lauren.
Yeah, thank you, Lauren. Get in there with some strength training. I'll be excited to know how you get on.
Charlie, did you want to come in to kick us off?
Yeah, please. I mean, so Bridgitte, I wonder, in terms of kind of how does a service get started in something like this? Obviously, you've touched on the kind of the barriers and the challenges, but is there like a first step if people are maybe a little bit hesitant about making a big investment, if they want to try something out before they really commit to something? I wonder kind of what the first steps would look like for a provider to start introducing that. Any kind of ideas about how you'd kind of go around that?
Yeah, great question. Thank you, Charlie. And as a kind of broad introduction to that, I would say that a lot of the feedback that we got from my study and from other studies is a huge part of it is the enthusiasm and the commitment and the expertise from activity coordinators. And it's them having the confidence to say, yes, I can deliver some of this. And I've got colleagues who are working on another study based up in care homes in Scotland. And some of the care homes that were the most successful with implementing that were the ones that actually had an activity coordinator who had a clear interest, like our question that came, they had a clear interest in developing resistance exercise or a background in exercise or exercise to music, and put their kind of personal excitement and motivation into that. So I think your staff, regardless of qualification, is the most important thing. If you've got some enthusiasm, particularly if you can get buy-in again from families and friends, to be a part of any kind of developing exercise program that you might put in place. That is a massive important thing, and it's one of those things which is like the secret sauce. We don't know how to kind of conceptualize that. It's the people that drive the programs that are your most important asset. 100%. You could have the best, sexiest, the most expensive equipment, and it might just sit there in a room gathering dust unless it's got somebody that's willing to invest some time and effort into it. Now, I think, again, if I talk specifically about the equipment that we used, the beauty of that was that the older adults, and they were able to use the equipment very confidently by themselves. They had a swipe card that was set up for them. All the machines had the reminder on what it was that they were going to do, and that, for me, like that's a job of a good coach. You need to make yourself redundant. You really want people to take personal responsibility for these things. Now, if we take that equipment out of it, your question, Charlie, is like, how would you get started? Really simple things like sit to stand. People just standing up out of a chair, or just every time they do it, they could just do an extra 1 or an extra 2 repetitions. Then you start to build that strength component in there. Just trying to make sure that people are not sedentary or not sitting for so long, trying to break up a little bit more of that sitting time, so that people are like standing, that they could be, holding onto the back of the chair for balance, but doing calf exercises, using resistance bands, using body weight, using light equipment would be a step the way you could take to see if there was an appetite for resistance training, and how, and how that could be embedded into the care home. I mean, we also had reservations because this equipment, you can see, was actually in the lounge, and we were like, I'm not sure whether that's a good place to put it. It should probably be in a dedicated room. And actually, I would say our learnings are completely opposite. Put it somewhere where everybody can see it all the time. And sometimes residents who even weren't involved in the study would just be in the care lounge and think, oh, I'll just do a set on that, or while the kettle's boiling for a cup of tea. And those like ad hoc movement things, it doesn't need to be like a huge strength training investment. It can just be a little bit more that's done. And you see in all the pictures there, everybody was just turning up in their normal clothes. There was one of the residents, David, just turned up in a shirt and tie every morning to do his resistance training. It's wonderful. So yeah, it doesn't need to be a huge investment, but I think my key things were there: enthusiasm and support through your staff, investing in your staff, particularly your activity coordinators, so that they can have some confidence in what they're delivering, working closely, as we were lucky to, with physios and other healthcare providers who can advise on some basic exercises that you can put in place. That would be my pro tips. Thank you.
I had a question as well, if that's
Sure.
all right. Bridgitte, just in terms of the trial, I loved the pictures, by the way. I thought they were great. Just in terms of the individuals involved, around the kind of the age of the individuals, and also the needs. Were there people with slightly more complex needs, individuals with dementia, for instance, and how that kind of plays into to what you have to take into consideration if you are looking to implement this sort of these sorts of programs?
Sure, great question, thank you. So in the 2 studies, in the first study, which was with the frail older adults, so these were people that were scoring at least 3 on the frailty scale. The spectrum of ages there was from 73 to 95, and the average age was 86. And on the second study, the average age was 80, and the age span was from 75 to 88. And I always tell the story because I just love it. In the first study, that the age span that goes from 73 to 95, there was just like a wonderful old married couple, and 95 and 96. And one of them actually didn't make the criteria to be involved in the study, because at 96, actually, he was too fit and healthy to be involved in the study. But they said that they would only do the study if they could do it together, because they did everything together and they would like to do it together. So this is why we've got such an incredible age span there. And going back to your question of were there people with complex needs? Yeah, indeed, that there were people in the study who were predominantly in wheelchairs, that we could help assist them to get into some of the resistance equipment. You can see there next to Doris, she's got her walker. Everybody was using walkers to get backwards and forwards. People did have diagnoses of, Sheena had vascular, early onset vascular dementia, people with diagnosis of osteoporosis, etc. But we do know that resistance training is actually safe and effective, even with people who are going to have these complex medical needs. And the reality is, when you're working with older people, the likelihood is that everybody's going to have some kind of medical diagnoses, not just frailty, which we know itself is complex. We made sure that the study was inclusive. So if people that had dementia, or like I say, Sheena had vascular dementia, it was open to them, and people could then give consent through like a caregiver or a family member. And I think it's a great question. I would like to see that we would expand this more broadly to include people who had a dementia diagnosis, and there's absolutely no reason why that couldn't be done. And interestingly, Norman, who wanted to look after his wife, we did several times get his wife to come down and do some resistance training, because he said that he'd felt it made such a change to his life that he would like his wife to do it as well.
Great. So it sounds like there's something for everyone in
Indeed.
resistance training. That's great. Does anybody have any final questions, comments, remarks of any kind? If not, which is absolutely fine, I think all that's left to do is to say thank you to Bridgitte, thank you to Nikki and to Trevor for helping us put on this really interesting webinar today. As I say, we have recorded the session, so we'll upload it onto our website and make sure that all of the materials are shared with attendees and the wider membership. So if you know anyone that wasn't able to make it today, they can access today's materials. I'm sure Nikki, Trevor and Bridgitte wouldn't mind if we share their contact details. If anybody wants to get in touch, please make sure to check out Sports Medical and everything that they have to offer in this area. And yeah, a big thank you for everyone taking the time out of their afternoon to come along today. So thanks very much, everyone, and see you all soon.
Thanks, everyone.
Thanks, everyone.
Bye.
Bye-bye.